Good evening, everyone, and welcome. I'm going to give a couple of minutes for people to get situated in here, then we'll start. Okay, I think we'll get started. Lots to talk about. On behalf of NAMI Mass, our board of directors, our staff, and our 17 local affiliates across the state, welcome to tonight's conversation. My name is Eliza T. Williamson, and I have the honor of serving as Executive Director of NAMI Mass. For those of you who joined us last week for the first webinar in our series, thanks for coming back. For those of you who missed last week's conversation with Dr. Inzel and Dr. Croft, we're happy you're here tonight, and you can find the link to the recording on our website. Tonight is part 2 in our 3-part series, A Changing Landscape, which invites families to explore how mental health care is shifting from a narrow focus on diagnosis and treatment toward a more relational, trust-building approach. The series highlights emerging ideas that emphasize people, place, purpose, and the role of strong, trusting relationships. Through expert conversations grounded in lived experience and evidence, families are encouraged to reimagine care as something built over time through connection, understanding, and partnership, not just clinical intervention. Created in collaboration with NAMI Mass, this program was shaped by Massachusetts mental health advocates Ray Simpson, Monica Luke, Phyllis Vine, Julie Huber, and Michelle Ward. So once again, tonight's program will start with a conversation followed by questions and answers based on the questions you put in the Q&A function. This is very important. Please put your questions in the Q&A function on the toolbar, not the chat. We won't be able to monitor the chat throughout this webinar, so please do use the Q&A function. After a short break, you're invited back to join us in a Zoom meeting to talk about what we've heard with other participants and our participants, excuse me. We hope you'll join us for that second segment. Our speakers may share resources or other information throughout this conversation this evening, and we will make sure to get that out to you in a follow-up email along with a link to the replay on YouTube. And of course, our NAMI Mass Compass Helpline has a deep set of resources on our website, and please feel free to call. Last week, we heard from Tom Enzel and Bevan Croft as we began to consider what is needed beyond the medical model. Tonight, we're continuing our exploration, turning our focus more specifically to psychosis. We're honored to be joined by 2 remarkable guests, Dr. Mark Ragins and Dr. Danna Mauch. Dr. Ragins is widely known for his innovative and deeply curious approach to working with people who experience psychosis. Grounded in the belief that everyone is different, his work centers on building authentic relationships and partnering with individuals to discover what truly works for them. Dr. Mauch brings decades of experience working with and advocating for families here in Massachusetts as well as across the country. She adds a vital systems level perspective, helping us think about how we can influence policies and structures so that more people can access with what works. Without further ado, I'm pleased to turn things over to Danna and Mark.
Thank you, Eliza. I'm very pleased to join my friends at NAMI and to welcome Dr. Mark Ragins to Massachusetts and to this conversation. As Eliza said, he has a long and important history as a founding member and clinical leader of a wonderful organization called The Village in Los Angeles County, California. It's really a recovery-based community that serves people who live with sometimes disabling mental health conditions. I was privileged to visit there twice over the years, and I had a further chance to talk earlier with Mark in preparation for tonight. And he reminded me, in paraphrased words of Hippocrates, that it's more important to relate to the person than the diagnosis. Tom Insel did mention last week that he has experienced the limitations of a strictly medical approach to working with people who live with mental health conditions. And that even though the, in quotes, problem might be something that's identified as medical, the solution is often social. And he does use this phrase of people, place, and purpose as essential to focus on. Mark has authored a remarkable book, Journeys Beyond the Frontier, a rebellious guide to psychosis and other extraordinary experiences. And in that book, he writes with so much care and respect, describing the people he knows, and also he writes about a framework, three intertwined dimensions or paths to recovery for people who live with these conditions and are working to rebuild a life. Relationships, experiencing reality, and self-identity are those three uh, dimensions that he describes. So, Mark, we look forward to hearing from you about what may perhaps be, for many of us, a new way of thinking about the experience of psychosis from both the perspective of our loved ones and the perspective of a doctor who's dedicated decades of his life to engaging with respect and treating with dignity people who live with psychosis.
Thank you for
Can
the sweet
you,
introduction.
pardon?
Thank you for the sweet introduction. Thank you, Danna.
Oh, you're very welcome. We're so happy to have you here. Would you share with us a bit about your perspective on psychosis, its causes, how people are living with it, what we might be thinking, how we might think differently about it?
So when I became a psychiatrist because I was interested in psychosis. I had the idea that people at the edge could see things that normal people in the middle couldn't see. And I even remember doing a paper in college about what's similar or different about the states that mystics go into, people who are using hallucinogens, and people with schizophrenia. And then I got to medical school and residency, and all they wanted to do was talk about diagnosis and psychosis and antipsychotic meds and positive and negative symptoms. And all the things I thought were interesting were left off. It was, if you're hearing voices and paranoid or delusional or stuff and it's gone on for more than 6 months and it isn't caused by drugs, we'll just call that schizophrenia or schizoaffective disorder. We'll just give you a bunch of antipsychotic meds and move on. And hopefully we'll stabilize you and nothing terrible happens. Can you imagine if it was cancer and we said, oh, you have cancer. I'm not going to try to figure out what caused it or what's behind that. We'll just give you all the same chemo and hope it works out. I was really interested in that everybody's story is different. One of the things I've noticed is that the average doctor, the idea is identify as fast as you can what the pattern is. So the diagnosis, you got a treatment and move on to the next one. I was interested in that the person in front of me, I've never met you before. I've never seen this before. There's going to be things about you that are different and surprising, no matter how many decades or how many hundreds of thousands of people I've seen. Each one is different. And what I discovered when I looked at that was that psychosis isn't just the business about hearing voices or being paranoid or having delusions. People have a whole life that unfolds. They even talk about this thing about a prodromal time when you start getting weirder and more distant from other people and stuff. And then you have a psychotic break and then you get stabilized or something like this. Except that lives don't feel like that. And what I realized is that some people begin with problems in their relationships. They get all isolated and paranoid. Some people begin with problems in their self identity. They don't know where they're going in life. They can't tell their own story. They're just lost. And some people begin by hearing voices or being delusional. But we don't call you psychotic until all three fall apart. If you just have weird ideas and you've got a lot of friends and know what you're doing in life and you're and you believe you bring people mystically from the dead or you came from another planet, that's fine. You start a podcast and you're on your way. if you have only that you have bad relationships but no delusions, we don't call that, we call that a personality disorder, or your favorite aunt or your least favorite aunt. We don't call that psychotic. We call it psychotic when you're lost in all these ways. And I think what's important is any of these three things can be the one that starts your problem. And it's like a three-legged stool. And once that falls down, if the other two fall down too, then you're psychotic. And if it keeps going on and on, you get stuck there for more than 6 months. And we call that schizophrenia. But we can get out of it in any of the three ways too. Too often we just say, let's fix your delusions, hallucinations, and we pay no attention to what your identity is. We even destroy your identity a good deal of the time, or who your friends are, your relationships, and we destroy that a good deal of the time. And then we wonder why it doesn't hold together with just meds or when you stop your meds. Any of those three can be the path for different people to help recover and pull things back together.
Well, I think you started telling us the answer to my next question, but perhaps you could talk a bit more about how you got so immersed in the recovery movement so early in your career.
So besides thinking that people who think weird things are interesting, I was the kid in third grade who asked why to everything and drove the teacher and my parents crazy. And like when they gave their answer, I didn't believe them and I found my own way, or argued up and back and raised my hand. Couldn't you do that this way too? And of course, some teachers liked that and some teachers hated that. When I got to college, I went to Caltech to college, very scientific. They love that because they're very into discovering scientific things. But when I got to medical school and residency, they hated that. Medic Being a doctor is one of the last great guild professions. You spend years learning not just these various facts, but how to act like a doctor and the culture of a doctor. Part of it is learn every word a doctor says is gospel, and don't dare contradict the other doctors in front of the patients, and act like you know the answers even when you don't. And what I realized is, wait a minute, you guys don't actually know that much about psychosis, and you're not even that interested. So when it came time to do electives, I went exploring. I went to the hospice, which I think is the single best person-centered recovery program we've got in medicine, hospice. I went to a substance abuse unit, learned how to do 12-step recovery. I was the only resident who went to any of these places. I went to the Meningers and learned psychoanalytic treatments. I went to Masters and Johnson's and learned sex therapy. I went to community mental health, learned about clubhouses. I even went to London and learned from the British Health Center how a hospital can be part of your community treatment and not an isolated island way over there doing its own thing. And I did the same thing in residency, especially I went to Skid Row, because that's where people who are to start on the edges end up in our country, especially in Los Angeles, is Skid Row. And I learned a lot of stuff there, how to help people's lives. And when I brought it back to the ER in the hospital and said, hey, look, I got all these resources and stuff, they said, oh, that's very nice, Mark, put it over there, but we're too busy. So by the time I finished residency, I was about where Dr. Insel is describing now. I'd seen all these things and wondered, why can't we do different things? And then disaster struck. My clinic was closed from budget cuts and poor leadership. And my best friend in the clinic was murdered by a patient, stabbed to death by someone with schizophrenia, not taking any meds and drugs, and homeless. And I think that's an important part of my story, because once you've lost things, you don't hang on to them as much. Well, some people hang on more and get more insecure, and some people say, yeah, life is short, let's just do things. And I was thrown a life raft of this program in the village that said, let's show the best we can do. And the best we can do is recovery-based programs, so all these kinds. So I was open-minded. I got to build a whole recovery-based system of care, a whole recovery way of looking at people with mental illnesses.
Well, I think your program is known for being person-centered. That's a concept you talk about in your book. I wonder if you might talk a little bit more about that.
Sure. This is the single most important item, is the shift from we're going to have you recover by we're going to treat your illness and then you'll be okay. That's not the way it works out. Versus we're going to help you have a better life maybe with your illness. Pain and suffering aren't things you necessarily get rid of or medicate away. They're things you grow and develop through. So to give you an example, at the end of a really good treatment and case with somebody, they might come back and say, "Hey, Dr. Mark, you're the best doctor I ever met. You really listened to me and it's really good. And you helped make a good diagnosis and gave me some good pills. And you took care of the side effects. And then you got me some disability to live on. And you helped me find a group home and a board and care to be with. And you take care of my money. Someone became my payee. And I don't have to make any decisions because you'll always help decide anything for me. And I know you're never going to go on any vacations or retire or leave. So I can always count on you to do things for me and stuff. And it'll be okay." I'm like, wait a minute. This started out so nice. He was saying nice things about me. And then it got vaguely creepy or vaguely crippled. A real recovery sounds like, I wouldn't have wished this on my worst enemy. The pain, the suffering, the struggles, the damage, the burden I've been, it's just unthinkable if you haven't been there. Unimaginable. But in some ways, I'm proud of the strengths that I've discovered in fighting this. Some of the most important things about myself I found in this struggle. It helped me realize what's really important in life. I wouldn't wish it on anybody, but there's been gifts from these wounds, blessings in disguise. That's what a real recovery sounds like. And
So
where
that's,
does that go ahead?
no, I'm sorry.
Those two paths divide that very first day when you come to see me. And if I say, "I'm the doctor, I'm going to fix you, just hang in there and we'll get this better," you're on the path toward vaguely creepy and vaguely crippled. Versus if I say, "I can already see in you the strengths you're going to use to overcome this." And I say this in the first visit with everyone. And I find them. The strengths are more important than your symptoms. Your protective factors, your resilience is more important than your risk factors. We're going to be able to get through this over time because you have the strength to do it. And I'll be with you as we're doing it. Then you're on the second path.
They're really reconceptualizing an approach to providing treatment and recovery supports. And that's unusual in serving people who live with psychosis and schizophrenia. I'm wondering if you could talk a little more about that reconceptualization and its relationship to the recovery model.
So, because of that first shift from illness centered to person centered, we don't have to make a different model for each diagnosis. Admittedly, schizophrenia is the most interesting one, and psychosis is the most interesting one. But that's like saying we're going to play Scrabble with only the X's, the Z's, the Q's, and the J's. You can't make any words like that. We'll build a system for everyone that is able to include them. So you can make words out of those really difficult letters. And for the person process, it is not my illness got treated and the symptoms went down and was put under and then it had a relapse and stuff like that. The person process looks more like, actually, let me use another metaphor here. You start with this river of suffering. You can land in this river all isolated and messed up and lost in lots of ways. You can have psychosis, you can have drug abuse, you can be lost in an immigrant journey, you can be teased and bullied, you can be neglected and abused as a kid, you can be raped, you can be homeless. Our society has lots of ways to end up drifting away. And in this river floating away, there's lots of people struggling, and it goes through lots of bad places. It goes through poverty, goes through homelessness, goes through jailing, goes through violence, both perpetrating and victimizing. It goes through suicide, goes through early death and terrible health. And when people see this, they say, "Oh, that's very bad. I feel sorry for those people." Go ahead and help them out, build a program, but just make sure you don't bring them anywhere near me. Don't have that river come near me. Build the program out in the middle of the river someplace. So we build homeless outreach teams, we build hospitals, we build state hospitals, we build jails, we neglect people on the streets. Just stay away from me. what the recovery process is, that first step is they're drowning in this river. Can we help you get to the shore? And then can we have the next step is engaging. Can we connect with you? Dry off a little bit. Let's look at the damage. What's going on? Where are you at? And it's good to be out of that danger, a little bit of sanctuary. The next stage is, well, it's a long way from here back. How are we going to rebuild? And that rebuilding isn't just how do we take care of your mental illness. That might be the part, it might not even be the focus at all. We might focus on drugs, we might focus on trauma, we might focus on education or jobs or isolation. Half of everybody at the village focused on, once they got a little better, focused on reconnecting with their families, because that gives you meaning. For some people, it's focusing on reconnecting with God and going back to church, reconnecting with your own children. What do you need to rebuild? This slow process of getting back together. And we do this in a lot of kind of sheltered settings, things like clubhouses and group homes and peer support things and support employment, things like this. And if you get to that stage, many people think, oh, I made it. I'm not in the river anymore. I'm not at that. Don't stop there, because you are dependent upon the system to keep your life going. And at any time, a president can show up and say, no more supportive housing, no more Section 8. All the mentally ill people are taken off of SSI. No more Medicaid to pay for things, no more clubhouses, no more whatever. It can just disappear. The next stage after rebuilding is reconnecting with the community, arriving. This isn't a safety net at the bottom in the river. This is the normal connections between everybody. This is, this isn't people, place, and purpose that's isolated. This is the same people and purpose, places as all of us. Can you get a paying job? Can you get an apartment or a home or roommates? Can you raise your kids instead?
So you're describing both some of the foundations upon which we would build better system, but also some of the elements of that system.
Mm-hmm.
I'd like to hear a little bit more about this, but first I'd like to ask about something you mentioned as as in this reconceptualization of the system and really a recovery-based model. How do families participate? And how is that conceptualized in a way that doesn't, evoke the old tropes of blaming families and that kind of thing?
Right. So the families can participate much more fully because this is about your person and not about your illness. You don't need to be an expert in psychosis or medications. We don't need to have you do tons of psychoeducation to learn how to be a miniature doctor in your very own household. You need to walk alongside these stages. So let's break them down, how families fit in for a second. Most families focus on that drowning in the river one. I got to help them. They're drowning. They're going to die. I got to send out people that are homeless, all these terrible things. And we focus on all those crisis services, all those things in the river, where you're least likely to be able to be helpful. But I'm not about to tell a family member, and I'm mixing metaphors here, either do run into this burning building where your family member is, or don't run into that building because you don't want to burn yourself up. Parents and family members are going to choose whether to run in or not, and we don't have any right to tell you not to, especially when we fired the entire mental health fire department back in the 1980s when we stopped doing that. But don't lose focus. That's not the whole game. So let's look at the three. The engagement one. I've seen families set up a homeless drop-in center in New Zealand where they ran it and people were welcome and they could come by. And many of these families were very compassionate because they themselves had had members who had been homeless themselves, or even they'd been homeless at some time themselves. They could make this welcoming. They could be the person who welcomes either the client or their family in that emergency room or in that first crisis call. They can run warm lines, connect to people, can be that welcoming that you don't often see in medical model services. They can be a volunteer in the clinic that makes people feel more at home instead of scared away by all our inhumane ways of doing things. I saw some great volunteers just in the waiting room, making the place feel much better. so you can engage. They can be able to call you up on the phone and say, hey, you missed your appointment. I know sometimes it's hard to come back. What happened? Maybe I can help you do this. The rebuilding one is crucial. Families can help so much with the rebuilding one. My favorite NAMI group ever was in Davis, California, because they weren't all in the rivers concerned with what the emergencies were going to be in life savings. They were running things, they looked like a PTA. They were running a bicycle club, they were running a backpacking club. One was doing how to do interviews to get a job. There was an arts group. They were raising money for a trip to go to Washington together. They were doing a gardening thing. They were doing, and the staff aren't particularly good at these things. The families doing whatever their passions were and relating to you through your strengths and through giving you purpose that isn't just an illness or isn't a group like that. And then the arriving one, families are crucial at, can we find welcoming hearts in our community? Can we find a landlord who will let someone live there? Can we find a physical doctor who will take people with psychosis? Can we find a bowling league you can be part of? Can we help use some of our network of friends to help you get a job or to help you around the college? See, when you look at it this way, families can be super helpful because don't worry about the illness part, worry about the person recovering, worry about their relationships and their personal identity, giving them all this meaning. And then what are we going to blame you for not sharing things in your life with people? It's when you start thinking that you need to find someone to blame for the illness that you do all this blaming things. And when you focus only on the disastrous parts, you can be so much more hopeful. And then you're looking for people to celebrate with instead of blame with.
Thank you for that. It doesn't sound to me like we can just add a couple of elements to and fill gaps in our current system as it's structured, particularly if its roots are really the medical model. I'm wondering, is this really about transforming the whole system? What's your advice for us?
I do think it is, although that's the hardest part of the easiest way to change things is we'll just add something, a little gravy, and we get a little money. That's the easiest one to change. All right, we can add a little consumer run program over here. We can put in a warm line. We can add these things. But there's never enough money. There's never gravy. And we're doing so much damage along the way. People have probably never done worse mentally than they are now. We're not even getting meds to work very well anymore. That we need the three things in a transformed system. One is the one you already brought up. That's the single most important is relate to people, not to illnesses.
Mm-hmm.
And our whole system is illness ready. What's your diagnosis? I'm going to pay for a treatment for your diagnosis. How does this medically necessary treatment? The whole thing's set up like this. We approve of a drug because it treats an illness. We even diagnose regular human experiences as illnesses in order to get them paid for.
That we do.
The second transformation is the switch between professionally driven and client driven. If I think it's all about me and making you comply with what I want you to do, I'm going to be more and more and more repressive, which the real hope for recovery, like in that person I was telling you about, is to bring your life force stronger, to bring it out in you. My job is not to repress you or suppress parts of you. My job is to welcome you, to empower you, to guide you, to share decision making with you, to find you opportunities, to walk alongside. And the third transformation is switching from deficit-based to strengths-based. You're not going to reconnect because you're cured. These illnesses are too hard to cure. You're going to be able to go on because you've made it with your strengths and resilience and your protective factors. Let me do a quick, weird story at this point. Winnie the Pooh from 100 years ago. You've probably seen this thing where they diagnosed all the characters in Winnie the Pooh. You know, Tigger has ADHD and Piglet or Roo is anxious and Eeyore is depressed and Pooh has an eating disorder. You know, they owl is narcissistic, whatever. But in real life, what's happening in this story is every one of these characters gets to come on every adventure without saying, you got to calm down your ADHD first, Tigger, before you come along. And every character contributes to every adventure, not in spite of what's different about them, but because of what's different about them. Christopher Robin is learning how to integrate all the parts of himself, all these things, all these traits, instead of getting stuck in one, or instead of having to get rid of one or medicate it away. He's learning how to integrate it to make it part of himself. And we as a society need to learn how to integrate and make all this part of ourselves too. So long as we're on the side that says we need to diagnose everyone with the illnesses, get rid of it, doctors need to tell everyone what to do, and it doesn't matter what's good about you, just we need to scrub the world clean of mental symptoms like the mental hygiene system. We've got too many things going the wrong direction.
We're talking about practice transformation if we're going to accomplish what you're suggesting. And I'm wondering about your thoughts about training opportunities for clinicians and also others who are critical allies, as you mentioned before, to making change happen and sustaining that change.
The number, to go back to where I started with my own experience, having more exposures makes a difference. We even know for psychiatrists, if they do a rotation in community mental health, they're much more likely to take a job in community mental health than if they never saw it in their residency. If they do a rotation in working with homeless people, they're much more likely to take a job doing that than if they never saw it. If they do a rotation with people with substance abuse, they're much more likely to take that. Our rules are set up so narrowly that says make sure you go inpatient, outpatient, consult and liaison, elderly children, learn all your pills, learn medicine, and make sure you can pass these tests. Rather than what kind of experiences can you have that you'll learn from. Almost everything I learned was from a patient or a family member or something like this, not from a book of something or other. So I think we have to have times when we need to listen to more voices and have more exposed. You think you should have trainings. Like I know someone who's a resident who's working on a project to have people with mental illness, including psychosis, train residents or give them classes so what it's like from their side. Actually, let me tell one story on that as a thing, because it goes. So late one afternoon, a guy walks into my office and he holds up his hand like this. He says, "What do you see?" I said, "I see your hand." He says, "No, be more specific." As you may all guess, this man has schizophrenia. I know lots of this. I said, "All right, it's late, but I can do this. I can see the swirls of your fingerprints. Everyone is different. I can see the creases between your knuckles, and I can see like your love line and your lifeline. I don't actually know which one's which, but I can see them." He says, "When you can see nails and knuckles and hair, you will be able to start helping me because you'll be seeing the world from my side and not from yours."
A lot of wisdom in that.
We need trainings that get you to see what's it like to experience these conditions. What is it like to hear voices? Or wear the thing with the headphones, listen to somebody. What would it be like to be paranoid and someone's going to attack you all the time? What would it be like to have your children taken away and have a big dark place in your heart that tears keep coming away from? What would it like to be so addicted that you end up prostituting and using and you can't get out of this and you can't see any hope to this? What would it be like to have tried to kill yourself and gone on, but know you're now different and marked for the rest of your life because you're someone who tried to kill yourself? You went beyond the pale. What would it have been like to have attacked your mom in a psychosis and try to somehow come back from that?
Important question.
Teaching empathy, seeing it through their eyes, instead of writing case history, a 32-year-old single white female with a history of bipolar disorder and drug abuse and obsessive compulsive traits. The way Tracy looks at the world is that she sees suffering everywhere. And in fact, she's kind of oversensitive to everybody else's suffering and picks up on these feelings. So it's hard for even be around other people much. And it makes her moods go up and down a lot. What's it like to be her? That's person-centered.
I thank you for bringing us back to that. And I know the people who are here tonight have questions for us, so I'm going to defer to Monica for that part of the program. And thank you again.
Thank you, Dana.
Thank you, Donna, for helping me step in. That was quite beautiful and emotional. Mark, thank you for closing your open conversation with that. We do have some questions that came in tonight. I encourage people, there's still time to put questions into the Q&A box. And I do have some questions. In fact, one that was brought up last week, and someone said, oh, Donna's the person to answer that question, which is, and in fact, Mark, you made the point previously that we don't pay for the things that work, and that actually they're often more cost effective. They're not necessarily wildly expensive. And so, here in Massachusetts, what can we do, or what do we know about the data on costs to sort of change what people have access to? While we wait for everyone to go visit a homeless shelter during their medical training, is there anything that the data tells us now that we could be doing now? And Donna, I think maybe that one's for you.
Well, we have had a compact for many years with our academic medical partners in Massachusetts. And some of the programs have had strong community psychiatry elements, training people to work in healthcare for the homeless, for example, in many of our community-based clinics, definitely training in the field. As Mark said, having to go through various rotations to meet the requirements of accreditation of the programs. But, it's a lot about clinical leadership. And we've been fortunate to have some very strong clinical leaders here. What's happened is that we have not always connected the progressive elements of training to placement in the progressive elements of the system. And we haven't taken all of the progressive elements of the system to scale. It's funny that Mark talked about the fact that if you don't expose people to things in training, they don't do it. When I was the state mental health director in Rhode Island, and we had a psychiatric residency and psychiatric research and training program, and people would talk about all the elements of it, I would say my job is to help these students embed themselves in life in our community and love Rhode Island. Go get addicted to Italian food. Go get addicted to the beaches. Come visit people wherever they are in our communities. Come to our homeless shelters. Come to our hospital. And be assigned to community mental health centers and get and feel connected. And we were very fortunate to retain a lot of people. Not every system has the luxury to connect that way to the community. And I think as we've seen cutbacks and we've seen this increasing gap between what people who choose after many years of training to do in practicing in psychiatry get paid versus people in other disciplines of medicine that don't require even as much training. We haven't seen as much interest in the field. And we've got a workforce crisis, and we have quite a bit to do to dig ourselves out of that.
I want to make one quick comment about the money. It's not actually following up on what Donna said, is it's when the village first started, we had capitated money. So we could buy what we were just paid up front so much per person, and we bought whatever we wanted with it. And then they did a comparison with the control group that the regular services and ours, and our outcomes were way better. But also our expenditures were very different. The top three expenditures in the normal system were hospitals, institutional care, and therapy.
Mm-hmm.
Meds were fourth. Our top three expenditures were case management, employment, and social community integration programs, going to your Italian restaurants with people. Meds were still fourth. This is not an anti-med program. You have to, we invested the money. And what I found was when I built protective factors, and protective factors means a reasonably safe place to live, some money to get through the month and to handle emergencies, some purpose in life or an identity besides a mental patient or messed up person, family connections, some other adult social connections, some spiritual beliefs and practice, and some emotional maturity. Those factors, when you build them, people don't need the crisis services anymore. So after a couple of years, I stopped racing around stopping crises and started building protective factors instead.
That makes a lot of sense. We have some the questions are now pouring in. I'm going to try to keep up with them, but one very I think common question is how do you balance the person-centered approach with the idea that people in psychosis or emerging into a psychosis aren't necessarily reliable narrators, and that the best way to serve them is to not listen to them.
Well, I doubt the best way to serve anybody is not to listen to them, because why would they listen to you if you're not going to listen to them? And unless you're just going to force them and repress them the rest of their lives. So it's learning their story and figuring out how I stay in the real world, but I'm interested in what's going on from their perspective so I can see how I can fit in. I'll give a quick example. A person came in, we found him, he was laying on a park bench for a couple of years, and people would come by and give him a little money and stuff. And our homeless outreach worker brought him in to see me. And he came in to see me and he said, I'm hearing demons in the palm trees outside of our place. My first thing was, let's go listen, show me, let's go listen to the demons in the palm trees. I want to meet him where he's at, literally. And we go out to listen to demons. He says, that's strange. When you're here, they're not talking. I said, well, it doesn't surprise me that much, actually. I'm not actually an expert in demons, but I have noticed one thing about them. They tend to be chicken shit. They tend to only pick on you when you're weak or when you're alone, not when someone's around, like me. So we figured out one treatment plan already. I can just be with you the rest of your life, and then the demons won't pick on you. But that's not the most practical treatment plan in the world, so we better come up with another one. Maybe I've got some meds that can help your brain be stronger so they don't pick on you. Maybe we can help give you your good painting. You can give a paintbrush and you can help paint the inside of our buildings, the walls, so you got something to do and you're around more, so you're not isolated on that park bench where the demons can pick on you. So I'm not saying he's reliable in describing how he's experiencing things. It's my job to figure out how I can fit into his world, not his to figure out how he can fit into our DSM classifications and our Medicaid reimbursement system.
It's a great answer. And I think the next question in some ways fits with that one. Can you offer suggestions for family members who witness their loved ones being treated by the medical model by mental health teams? What might be some effective ways to interact with a mental health team to provide the kind of person-centered support for our loved one?
So that's a good question. I haven't thought about, but some off the top of my head, my first answer is to try to humanize them as much as possible, and not humanize them with the story of the way they were before they became sick. That's a way of saying, can you bring back my long lost person? I don't value them the way, well, it's not I don't value them, but the way they are now, there's all these problems. I'm saying humanize them exactly the way they are now. Things that, what did they do this week that was special along the way? Tell them about traits themselves and so they see them. You have a great chance of converting a psychiatrist if you look at their desk and they have all kinds of little gifts from their patients laying there, or drawing someone or things like that, because those are special moments they connected as a person. You want them to connect to them as a person, not as, can you get rid of this illness for me so I can have my old person back again along the way. Let me tell one other quick story on this. Well, actually, never mind. Let's go on to another question.
Um, this is actually probably digging into some uh, more difficult space, maybe, but how do you stay person-centered and stay safe if a client threatens to kill you?
So you're so safety is a tough one. We all do safety in different ways of trying to keep ourselves safe. There's going to be layers of how you're going to do safe. From I'm going to call the police and get someone outside to do things. I'm just so big and strong, I'm going to do it. A lot of mental health professionals believe, oh, they would never do it to me because I have a special relationship or I understand so much it wouldn't happen to me. It turns out that safety isn't about protecting ourselves and building walls. Make sure you've got the room set up perfectly and get all the weapons out of the way and all this stuff. The room's set up perfect. Safety is about connections, and you're not doing it alone. The single most dangerous position is to be by yourself. There's so many things I could do with someone when multiple people in the room that you can't do in a little room by yourself. The first thing is, if someone wants to kill you, I don't want to be alone like that. And I'll tell people, if someone seems dangerous, I say, that they'll someone else will be sitting there, because I often saw people with other people around. They say, well, can't we talk privately somewhere? And I say, you know what? Not yet, because I've had this friend who was killed doing this, and I don't want to be thinking about my safety all the time. I want to be able to connect to you. And I know I'm safe with these other people around watching over what's happening. And we'll talk. And after a while, maybe it'll turn out I shouldn't be frightened of you for any reason and stuff. But it takes me a minute because of stuff I've been through. And I do a fair bit of self-disclosure like that. So they see me as a person too. Lots of the violent things are because we're clashing and not seeing the vulnerabilities in each other. They really can lower the violence in hospitals by doing trauma-informed things, and seeing that they're as scared of you as me. But nonetheless, if you're there and someone's attacking you at the moment, this is the time to be. Oh, so an early story. We went to a little apartment with someone. Their mom called it to see them, and they had been badly sexually molested as a kid, and they were paranoid and stuff. And we went in there, and she's on her. I didn't go alone. I went with the social worker, and she's on her bed there in this little rundown place, and she's what the social worker called her Jack Nicholson eyes, and she looks like she's scared and stuff, and she's yelling at us, and we're there to evaluate. She should be hospitalized, and we're there. She picks up the radio next to her and she throws it, and it smashes on the door 1 inch from my head, and we back up quickly and get someone to help us hospitalize her. And the social worker says to me, "So, Mark, what were you thinking while that was going on?" I said, "Well, I was trying to figure out, was she having a flashback to thinking I was like her brother who molested her growing up, or was this a paranoia that was doing it?" And the social worker, "What? I was thinking duck." When you're actually being attacked, respond to the attack. This isn't time for elaborate intellectual things or elaborate things, but you're being attacked by a person, not by an illness. But you don't have to be in danger, but you do have to take some risk to do this job or to be living with someone. That's why I said, I can't tell you whether to go into the burning building or not go into the burning building with your family member, or whether even as a job. This is your choice.
I want to say from a public policy perspective that we have to find a way to look dispassionately at how we staff programs without demonizing the people who use the services, but recognizing that for that person's good and safety, and for that of the people working there, you need to build in the capacity to ensure everybody's well-being. The other thing is about families, and I've been in this situation myself. You know, you think you can manage it. You're also sometimes hesitant to call others into the middle of it, and you can get very isolated. And these are things where, you know, we need need to be less afraid to ask for support.
This is also a good time for a multifamily group or a supporter, or it doesn't even have to be that official. But that's back to the most dangerous thing is isolation
Mhm.
for both the perpetrator and the victim.
On that rather uplifting note, I'm going to turn it back to
Well, that was a
Eliza.
kind of negative question. It was, I shouldn't
It
say negative
was.
question.
But
It,
actually, I
it,
think
it,
it's something where I'm trying to say we can do better, and
Yeah.
everybody will will
Actually,
come out of
actually,
it better.
actually, let me say one last thing about that on a personal. So I was in a mess for about a year and a half after Robin was killed. And after a while, I figured out that I had three choices. One is I could say, never mind this. I'm a smart girl. I go to Beverly Hills. Never mind this. I don't need to be working with homeless people and psychotic people. I'm not going to risk my life. I got kids and I'm not doing this. The second one is I could build up more and more and more defenses and treat them at a distance in some ways, which won't actually work. You can't help someone at a distance. Or the third one was what we taught we teach rape victims. You never can be sure you're safe. But if you let the fear beat you, then it's stopping you from doing what you really love and your passion is to want to do. You don't have to do it alone. You don't have to, you can have some training. You can have extra things around for protection. You can have security. You can have buzzers. You can have other people around to help. But I have to have low interpersonal walls in order to actually make a connection to help somebody.
and now we do have to turn it back to Eliza to close us out.
Okay, I'm
And I cannot thank you both enough. You are, this was an amazing and engaging conversation. I appreciate you both.
Yes, thank you so much. I thank you, Donna and Mark. Once again this week, my brain is buzzing. And I think what's jumped out to me the most in listening to your conversation is that in some ways, trust is almost a precursor or the therapeutic container, and that authentic relationships built over time where power is shared creates the safety and the environment that makes any other support possible. Um, I just want to say, and I promise I won't go super long, so don't panic, anybody. Um, but that really rings true to me personally. Um, I live with CPTSD and I've experienced psychosis. And I've worked pretty hard over many years to learn to manage it. But I remember very clearly in the beginning how terrified and unsure I was about what was real. And I kind of at times thought, is this the beginning of the end for me? And I didn't know what I could trust. And I think there was something, I felt like I had an aha listening to the two of you because of course, when everything is scary and unfamiliar, the last thing anyone wants to do is engage with new people or try new strategies, much less share what's happening internally, which probably feels scary and embarrassing. So for me, and the other piece that feels important and interesting about that is that is that while my thoughts, and I imagine others' thoughts, are distorted, my relational attunement was not. In some ways, I think I was more acutely sensitive and hyper alert to inauthenticity. I knew who was going through the motions and talking at me rather than, with me or being with me. And so for me, I think, interestingly enough, the relationship almost was the intervention because it enabled me to hold ambivalence, and stay engaged through hard things and to keep trying and, feeling safe and seen, and important helped me do that. So thank you for bringing me that epiphany. Um, and thanks to all of you who joined us tonight exploring these ideas. Um, these are not easy questions, and there's no simple answers. And perhaps the first step comes with just a willingness to imagine that more is possible and approach it with curiosity. If tonight's conversation sparked reflection or raised new questions, please do come back and join us, for the following talkback discussion starting at 8 for up to 45 minutes. You'll receive an email shortly with a new Zoom link, from Courtney, and she'll also drop the link in the chat. And once we're together, we'll provide some guidance and prompts, and hopefully we'll all engage again. Reminders, you will get the email with resources and links next week. And finally, as you all know, next week we have our final webinar in this series. We'll welcome Dr. Cheryl Bellamy and Paolo Del Vecchio to talk about their work to address social isolation. So please do join us. We'll look forward to seeing you on Tuesday, March 10th at 7. And again, next week we will, the webinar will be followed by an optional discussion. So thank you, and hopefully we'll see you in a few minutes in the other room.
Thank you.
Thanks.
Thanks.